everyone, I am Meena. I am going to talk about Nocardia brasilensis. General characteristics. Gram's classification. Gram-positive bacteria. Shape rod-shaped bacilli. Motility non-motile. Capsule absent. Endospore absent. Respiration aerobic. Optimum temperature 25 degrees Celsius to 37 degrees Celsius. Optimum pH 6.5 to 8.0. Habitat found primarily in soil, decaying plant matter, and freshwater and saltwater environments. Discovery first described in 1909 by Lindenberg from a case of mycetoma in Brazil, formally named as a species by Edward Piney in 1913. Pathogenicity or disease transmission. People or animals transmission occurs through environmental exposure. Direct traumatic inoculation into skin and scratches introduce bacteria causing cutaneous forms like mycetoma. Contaminated objects facilitated skin entry during wounds. Incubation period 3 to 5 days. Virulence factors. Cell wall lipids, cod factor resistant to intracellular killing, catalase and superox dismutase, biofilm formation, enzymes, granule formation. Pathogenesis. Environmental bacteria enter via skin trauma or inhalation of dust, initiating localized cutaneous or pulmonary infection. Filamentous rod evade initial phagocytosis using mycolic acid rich cell walls that block phagosome-lysosome fusion. Catalase and superoxide dismutase neutralize neutrophil oxidative burst, allowing intracellular survival in macrophages. MCE proteins and invasins promote host cell entry, action, polymerization, and bacterial dissemination. Phospholipase and hemolysins disrupt membranes, causing tissue necrosis and abscess formation. Protease degrade extracellular matrix, facilitating spread from primary site to lymph nodes or bloodstream. In immunocompromised host, hematogenous dissemination targets brain, vertebrae or kidneys, forming abscesses. Chronic granuloma development involves persistent antigen triggering Th1 or IL-17 responses, but inadequate neutrophil coordination leads to suppression. Cytophores scavenge ion from host, sustaining growth during inflammation. Excess cytokines TNF-alpha, IL-1 beta amplify neural damage. Mycetoma form shows biofilm-like grains in pus, resisting antibiotics and promoting sinus tracts. Next, clinical disease. Nocardia brasilensis primarily causes cutaneous nocardiasis. Mycetoma and lymphocutaneous infection can lead to pulmonary disseminated and central nervous system disease. First one, cutaneous infection. Most common from traumatic inoculation includes mycetoma. Mycetoma is chronic subcutaneous swelling with sinus and grains. Lymphocutaneous syndrome is sporotrichoid nodules along lymphatics. Cellulitis, abscess, ulcers, and pustules. Affects immunocompetent individuals post-trauma and progress slowly with suppression. Example, throat scratches. Next, pulmonary infection. Inhalation causes pneumonia, consolidation, cavation may spread contagiously to pleura or hematogenously. Presence with cough, fever, dyspnea, chest pain. More aggressive in immunocompromised patients. Next, disseminated disease. From primary lung skin spreads via blood to brain, kidneys, bones, joints, eyes, or heart. High mortality. Risk factors include immunosuppression, fertility rises with delay in diagnosis. Next, laboratory diagnosis of Nocardia brasilensis. Microscopic examination, gram staining, violet colored gram-positive rod-shaped bacteria, motility test, non-motile, colony morphology and culture medium. Paraffin agar uses Nocardia's unique paraffin metabolism as carbon sources, suppresses Mycobacteria, Streptomyces and sputum flora while promoting wrinkled colonies. Modified Martin agar contains vancomycin, colistin, nystatin, trimethoprim, highest recovery from respiratory samples by inhibiting gram-negatives and fungi. Blood agar colonies grow slowly 3 to 21 days, appearing chalky wrinkled mate, white to orange or red color. Biochemical test. Catalase test positive, oxidase test negative, urease test positive, indole test negative, methyl red test positive, workers pescaya test negative, citrate utilization test variable, gelatin liquefaction positive, nitrate reduction positive. Next, treatment and preventive measures. Nocardia brasilensis infection require prolonged antibiotic therapy 6 to 12 months due to slow bacterial clearance and high relapse risk. Trimethoprim sulfamethazole first line monotherapy for cutaneous disease. Combination with ampicillin impenin for pulmonary CNS cases. Duration minimum 6 months total or 3 to 12 months post sterility based on site immunocytes. Wear gloves, closed shoes, long clothing during gardening construction to avoid soil inoculation. Trimethoprim sulfamethoxazole prophylaxis recommended for high risk immunocompromised patients. Thank you.